So many years ago, when I was in high school, I wrote a college application essay that went something along the lines of, no, actually it was for medical school, so it was when I was in college, but it was still a long time ago, that said, medicine is an art that aspires to be a science. And of course, that was not my quotation. I was not the first person to say that. But I think nowhere is that more apparent than when it comes to the microbiome. And the testing, this is really a science, if you will, or perhaps an art that is in its infancy. And this, of course, is a time when areas like this are prime for people capitalizing on testing and diagnosing and treating. So generally, the less we know, the more testing there is and the more therapies there are. And I think that's true of most things in medicine. So I think that you will agree with me as we go through this module on diagnosis and testing, that we are to some extent stumbling around in the dark. And it's really important to have a fluid sense of diagnosis and testing when you think about Sibo and dysbiosis in general, and not to be very rigid. And I always say we treat the patient, not the test, because it is something that is really just beginning. There's a lot we don't know, and the testing is deeply flawed. So I'll start with that. I will also say that we are losing the art of physical exam and history. When I'm in the hospital with medical students and even GI fellows who've already gone through medical school, 3 years of residency and 3 years of GI training with our senior fellows, I'm amazed that the first place they go is a computer, not the patient. And often they haven't examined the patient. They haven't done a rectal exam. They haven't taken a good history. They're telling me about the CAT scan and the blood count and so on. So this is a field also where it's really crucial to get a very good history. And when you can, if you're there with the patient, to do a good physical exam, looking for evidence of yeast overgrowth and things like that, looking for tympany on exam, where you can tap the abdomen and see if you can feel a lot of gas in there. So these are all things that are really important. All right, so enough with the preaching. Let's get started. So the first thing I want to emphasize again, and I'll emphasize it again and again, is that Sibo is a clinical diagnosis. It is not a diagnosis that we make based on culture of fluid in the small bowel or breath testing or microbiome sequencing or any of the other modalities or intestinal permeability test for leaky gut. It is a clinical diagnosis based, again, on the patient's history and symptoms. And this is where, again, from part one, the checklist comes in handy, as well as your, at this point, thorough familiarity with the multifactorial etiology of Sibo and all the different things that can contribute to it, and all those breadcrumbs we talked about in the last call of C-section baby, picky eater, tonsils out, antibiotics for acne, proton pump inhibitors, et cetera, of risk factors. So clinical diagnosis. I want to start with breath testing because it is sort of the dominant theme of this module. And you'll see it abbreviated throughout the slide set as BT for breath testing. And to break it down into sort of simple stages of how this works is that various gases are produced in the intestinal tract, throughout the intestinal tract. They diffuse into the systemic circulation, and then they're expired through the lungs, basically breathed out through the lungs. So that's a basic mechanism. There are four main sources of intestinal gas in terms of where does it come from. One is that we can swallow it, and we typically do swallow it when we're breathing, when we're eating and drinking. In addition to air going into our airway and down into our lungs, there's a fair amount of air that will go into our digestive tract. And of course, this can be increased if you have a condition called aerophagia or air swallowing, where you're inadvertently sort of gulping in large amounts of air. If you're somebody who's prone to chewing gum or sucking on hard candy or talking while you eat or drink, or if you have a deviated septum and you're a mouth breather, these are all things that can predispose you. Smokers are predisposed to swallowing even more air, but normal healthy people swallow some air just during the course of the day. And of course, there is air mixed in with certain foods also. So that's one source. The second source are chemical reactions in the gut. The third is diffusion of gases from the bloodstream into the GI tract. So it can go both ways. Gas can diffuse from the GI tract into the bloodstream and from the bloodstream into the GI tract. And then the fourth, and the one that we're particularly interested in tonight, is microbial metabolism, primarily of carbohydrates. In healthy subjects, people tend to have somewhere around 100 milliliters of intestinal gas. And the range is from about 30 to 200. We all know people who are gassier than others. You know who you are, but about 100 mLs. And I will say that for most people, I like to explain it this way to patients, where we all have passive diffusion of gas through our rectum, the same way we breathe, and we're not so aware of it. We're breathing, but if I go and take a big sigh, that's a very purposeful expulsion of air through my upper airway. So when you pass gas, when you are flatulent or fart, that is a more purposeful expulsion of gas, but that's not the only expulsion. So we're all passively diffusing various amounts of gas through the lower GI tract that we're, for the most part, unaware of. And this is why this combination of being constipated and having bacterial overgrowth and excessive gas production is such a problem. And the first thing that I tend to do, I know this is a little bit jumping forward to treatment, but it's so important when people come in and you're treating them for Sibo to take care of their constipation, because sometimes they don't have excessive gas production, but the problem is that they're plugged. And so even a normal amount of gas, like that 100 mLs, cannot escape through the rectum because it's plugged. So if you can try and remove that plug, you can improve the passive diffusion of gas through the rectum, and that can often debloat people and make them more comfortable and so on. So I just want to pass that on as a little bit of pearl, because people can be constipated. Of course, constipation can be part of Sibo, but people can be constipated for all sorts of other reasons, because of medications they're taking, like antidepressants or iron supplements or aluminum-containing antacids, or any one of a number of drugs, because they are women with a voluptuous venous colon, where the colon has lots of twists and turns to it, and the products of digestion have a difficult time getting out, because they're hypothyroid, because they are sedentary, because they have diabetes. Of course, a lot of the things that predispose to Sibo also, because they don't have enough fiber in their food, because they're dehydrated. So you can have somebody who's constipated on top of having Sibo, or you can have somebody who's constipated and thinks they have Sibo because they're plugged. So it's very important to try and fix the constipation as much as possible, even before really sort of rolling your sleeves up and addressing the Sibo, because that can often help dramatically with the bloating. So what type of intestinal gas are we producing? The primary gases in humans are hydrogen, carbon dioxide, and methane. And then secondary gas is oxygen, nitrogen, hydrogen sulfide. There's some ammonia, also a sort of a lesser gas. But the two we're primarily concerned with are hydrogen and methane. And hydrogen and methane are produced exclusively via microbial fermentation in the gut. So there's not really, you can't, some of those other mechanisms I mentioned, you're not swallowing hydrogen and methane with food, or if you have aerophagia, or any of those other modalities. So this is really a product of microbial fermentation. And of course, healthy subjects ferment food and produce hydrogen and methane too, just not excessively. Earlier, actually it was last year, I was going to say earlier this year, but of course we're 2018. In 2017, the American College of Gastroenterology, the ACG, published a consensus paper on breath testing. And this group got together and they published this paper because there was such a dearth of standardization for breath testing. There were no really well-established and well-accepted standards for indications for testing, preparation for testing, performance of testing, meaning how was the actual test being done, and interpretation of testing. It was sort of the Wild West. And there was a meta-analysis where they looked at 13 different studies looking at breath testing for Sibo, and every single one of these scientific studies in the meta-analysis, each one of the 13 used different modalities, different standards. One used lactulose, one used glucose, one used 75 milligrams, one used 50, one used 25. So there was no standardization whatsoever throughout those 13 different tests. So you can imagine the challenge that poses when you're trying to, for example, you're trying to discover what the prevalence of Sibo is in people with diabetes, and you're using 13 different tests to determine whether somebody has diabetes or not. And so you start to see some of the challenges that we're faced with, because of course a consensus statement does not mean that people adopt that the manufacturers of the test or those of us interpreting the test. I'll tell you, most people who are looking at breath testing don't even really know what the reagent is or how much is being used. I would guess that most of the physicians ordering it, they just think, oh, it's a breath test, let me order it. So we still, despite this consensus group and consensus statement, there is still a lack of uniformity. But these are the four big areas: the indications, preparation, performance, and interpretation. So I want to run through these four areas with you, and again, point out that just because a paper was published in the summer of 2017 doesn't mean that things have really changed that much. So the consensus on preparation said avoid antibiotics for 4 weeks before testing. And even before we get into the meat of this, I want to tell you, I have been on some of these consensus boards before. When I was on the board of the American Society for Gastrointestinal Endoscopy, I was part of the group that put out the consensus statement on the need for antibiotic prophylaxis before endoscopy and colonoscopy. And I'll tell you that we were very diligent in combing through the literature and so on, but there were so many holes in the knowledge where we didn't know, and we literally kind of, pulled it out of our tush sometimes. And that is sometimes what happens. Or you have somebody who knows a lot and sort of dominates the group, and some people who know less. So these were all very distinguished people, but this is a nice way of saying some of this stuff is just made up, quite frankly, because they didn't have really good scientific evidence to support things one way or the other. So they kind of came up with, they winged it. But the consensus was that if you're undergoing breath testing, you should avoid antibiotics for 4 weeks before testing. Now, why 4 weeks and not 6 weeks or 8 weeks or 12 weeks or 2 weeks? We don't have strong data to say that 4 weeks is an absolute. And therefore, what that means is that some people who do breath testing who were on antibiotics for 6 weeks before might still have a false negative breath test because they're still seeing antibiotic effect and they have low counts of bacteria. And somebody who had antibiotics 12 weeks before might still be seeing that. So 4 weeks is a little bit of an artificial cutoff. And in general, the further away you are from a course of antibiotics, the more likely you are to have a more meaningful breath test result, because we do know that antibiotics will increase the likelihood of a false negative result. In terms of whether it's okay for you to be taking a prebiotic, whether that's in the form of an actual food, a high inulin-containing food like leeks or garlic or white beans or asparagus, or whether that's in the form of a fermented food like kimchi or sauerkraut, whether that's in the form of a supplement like an inulin or acacia fiber. So probiotics, no consensus on whether you should stop that or not, and on prebiotics and also probiotics. So if you're taking an actual probiotic, the definition of which you all know is live bacteria that when ingested are supposed to confer a benefit to the host, meaning the person who's taking them. The second part of that definition, they're supposed to confer a benefit, is the tricky part. We all know that there are lots of products containing live bacteria out there. Whether they confer a benefit to the host is a different matter. But again, there was no consensus on whether if you were taking prebiotics in the form of a food, like a fermented food or an inulin fiber supplement, or if you were taking a probiotic, whether that would affect the test. Now, I think most people would agree that those two things together, or either one of them on their own, are likely to affect the test, right? Because the testing, as you all know, really limits the amount of fibrous foods and sort of complex carbohydrates that you can eat. And also, if you're taking a really high colony count, a probiotic, a very robust probiotic that has a high CFU, colony forming unit count, like the one we use in our practice a lot, VSL number 3, where the prescription strength is 900 billion, it's sort of hard to imagine that that's not going to affect the test, depending on the timing. But they couldn't reach consensus on that, so there really is no consensus. And so we don't really know what to advise patients. The third is that pro-motility drugs, so drugs, for example, like Reglan or domperidone. Reglan is metoclopramide, or domperidone. Those drugs that help to promote motility or laxatives should be stopped 1 week prior if tolerated. again, that's sort of the if tolerated. So in other words, if you have severe gastroparesis, delayed emptying of the stomach, and you are on a drug like domperidone to promote motility, and if you don't take it, you might end up with severe abdominal pain and even vomiting. They're saying, well, in that case, if you're not tolerating being off it, you should continue to take it. But of course, that's going to affect the test also, because the less motility that you have, the slower the motility in general, the more stasis and sort of backup there's going to be in the small intestine, and the higher the concentration of bacteria, and the more likely you are to have a positive test. So the reverse is also true. If you're on a pro-motility, or sometimes we call these drugs prokinetic drugs or laxatives, those drugs can increase transit time through the gut and may result in a false negative test. So that's another sort of question mark. So ideally, you should be off these drugs for a week before testing, or if you have a patient who's on them, you should ask them to be off them. But we also don't know if a week is adequate washout time for some of these drugs. But the bottom line is drugs that can affect motility should be avoided a week before, because they can lead to false positives or false negatives. Typically a false negative test if you're taking them because of the increase in motility. Fermentable foods, like some of the ones I mentioned, complex carbs should be avoided just the day before breath testing. But again, when you think about it, if the typical transit time from mouth to anus is somewhere between 12 and 72 hours, with average being about 36 to 48 hours, avoiding them just the day before might not work. If somebody has very slow transit, a lot of that fermentable stuff might still be in the small intestine, not yet in the colon, and could interfere with the test. And then the last point here is that the fasting period prior to testing is 8 to 12 hours. And that's sort of a combination between, an ideal fast would be 24 hours, but that is really a bit of a hardship for most people to fast 24 hours. So it's sort of a compromise at 8 to 12 hours. So this is a consensus, or maybe the lack thereof, on preparation. And again, it's a start, right? It's better to have some guidance than no guidance. But I want you to remember that these things are not, set in stone, and this is not the last word on this. This is what this group of people came up with, and I'm sure we'll see additions and subtractions and changes to this over time. So let's go on to the consensus on indications. The first is that our previous ways of testing for small intestinal bacterial overgrowth, which is culture of the small bowel, typically at endoscopy, we try and get far down into the small intestine. Difficult to do, especially with a standard endoscope, which typically only goes to the duodenum, the first part of the small intestine. So getting down into the small intestine is divided into three parts: the duodenum, the jejunum, and the ileum, in that order. And ideally, you want to get an aspirate from the mid part of the small intestine, the jejunum. You essentially can't do it with a regular endoscope, so you have to use a special scope called an enteroscope, a small bowel scope. And those are larger and bulkier and more difficult to use, and lots of people don't do enteroscopy. And the patient has to be really well sedated because it's an uncomfortable test. That longer scope tends to loop a lot in the small intestine and cause a lot of discomfort. So patients have to be really, really well sedated. And so typically you would use that long enteroscope, and you would suck out some of the fluid from the jejunum, and then you would send it off to the lab to be cultured, which is a very sort of long and painstaking process. But they determined that small bowel culture techniques were really not satisfactory. Not only was this a very cumbersome test that required endoscopy in a hospital or ambulatory care setting, and sedation and time off from work and all the rest, but that the results were really not reliable enough. They did say if culture was used, which it rarely is, that the cutoff is 10 to the third. So 1,000 colony-forming units per ml should be greater than or equal to be considered overgrowth. Okay? The third point is sort of a mixture of the first 2 points, which is that breath testing is a preferred modality for diagnosing Sibo. So you don't really have to think too much about culture, because nobody's really doing it, and I doubt you're ever going to see a jejunal aspirate culture other than within a clinical trial that's being done. The fourth point was that if the patient you're seeing, or if you yourself are the patient, If you have constipation and slow transit, you should do the kind of breath testing that is also measuring methane, not just hydrogen. And we'll get into that in a minute when we talk about the different tests. The fifth point was that breath testing is not an accurate way to assess what we call orocecal transit time, meaning oral, mouth, cecum to the colon. So people use this a lot, like to use it to say, well, somebody has slow transit based on the results, but it's not an accurate way to assess transit time. The same thing for some of the other modalities, like video capsule endoscopy, the little pill cam that you might have seen or heard of that you swallow and it takes pictures through the small intestine. You cannot extrapolate and say, well, the video capsule took 11 hours to go from the stomach to the colon, therefore the transit time through the small intestine, which is from the end of the stomach to the beginning of the colon, is 11 hours. Doesn't work that way because the solid phase emptying of something like a video capsule, which is like a little hard pill, is different from the transit time of the products of digestion. And similarly, transit time as reflected in how long it takes a reagent to get down there and to be metabolized by bacteria is not an accurate reflection of transit time for actual food. So that was an important point. Another point they made, it's a little bit not completely germane to what we're talking about tonight, but I'll mention it anyway, is that breath testing is useful for diagnosing carbohydrate maldigestion, so fructose malabsorption and so on, but we're not really going to address that tonight. And the last point is that breath testing is useful for assessing bloating because, of course, your patient might have bloating because they have Sibo or because they have lactose intolerance or fructose intolerance or anything else, so that it's a useful test for assessing bloating in addition to Sibo. And to confuse matters, of course, bloating can be a manifestation of Sibo. The consensus on performance, I'm going to simplify and just say that of the 4 reagents, which are all sugars, lactulose, glucose, fructose, and lactose, the 2 that are used primarily for Sibo testing as opposed to carbohydrate maldigestion or malabsorption are the first 2, lactulose and glucose. So forget about fructose and lactose for now. And for the lactulose testing, it's 10 grams that should be used, and for the glucose breath testing, it's 75 grams. Does not mean that's actually what's being used by the person who might be in your office trying to convince you to use their breath test or the one you might be ordering, but that was their consensus on what should be used. The consensus on interpretation, there is a lot of heterogeneity within the testing, and I think I've made that point, so I won't flog that horse to death. The second is that there is a lot of variability in methodology in different studies, and I think I've made that point also when I talked about that meta-analysis looking at 13 different studies, and every single scientific study had used a different version of the test. The third is something you may also be aware of, which is that Sibo can cause a false positive test if you're doing a carbohydrate malabsorption test. So again, I'm going to go back one slide, and for example, if you're doing a lactose tolerance test and you have Sibo, you can see high levels of hydrogen that would suggest a positive test for that, but it could be because of the patient's Sibo. So they really recommended excluding Sibo first in anybody where you're doing carbohydrate malabsorption testing. And then the last 2 points I bolded and underlined because these are the numbers that if you're going to remember a number, because remember we're dealing with something that is an art aspiring to be a science, so numbers are perhaps less important than we like to think they are. But if you want to remember a number, remember an increase in hydrogen of greater than 20 parts, it's really greater than or equal to, I apologize, I forgot the equal to sign. But an increase in hydrogen of greater than or equal to 20 parts per million by 90 minutes is suggestive of a positive test. And an increase in methane of greater than or equal to, again, I should be on that one too, of 10 parts per million is a positive Sibo test. And those of you who are familiar with the Genova testing know that they changed the format maybe in the last year. They used to just report the hydrogen, and now they report both the methane also. And there's also a 2R and a 3R, and somebody had a very good question about that, so we'll get to that in the question part. So that's breath testing sort of in a nutshell. I really don't think it's worth going over. We included it in the ebook, but which one is better for distal, Sibo versus proximal, because the truth is it really doesn't matter. That's really, other than in a clinical trial, that's not a clinically useful distinction, in my opinion. So I'm just going to leave that there. So I want to turn a little bit now to microbiome sequencing. And I want to talk to you all as colleagues and as patients, which means I'm going to be very honest and tell you that it's not helpful. And I know my friends at Ubiome, Jessica Richmond, one of the co-founders, would be very unhappy to hear me say that, but it's the truth. We've done in our practice probably more microbiome sequencing than outside of the companies. I mean, we've done a lot, let me put it this way. We've done thousands of patients, because when the testing was first widely available, we were doing it on everyone. And there's some really good things about microbiome sequencing. Number one, it's fairly inexpensive at this point. This is a test that costs under $100. It's simple. You swab the toilet paper after a bowel movement. It's quick, even though you might have waited 10 weeks for your results. The truth is it's a test that can be done very rapidly by the folks that do it. But it is, again, a science that's in its infancy, and I see what's happening here is people are really desperate for something actionable. Practitioners want to be able to say to their patients, you have A, B, C, so you need to do D, E, and F, and make it very sort of matching the treatment to the results of the test. And unfortunately, we're not there yet. So if you're familiar with any one of it, whether it's Human Gut Project or Ubiome or Viome or any number, I mean, the Zoomer, there are tons of companies now that do this. And it's all this DNA extraction technique. There's some information in your book about it. We don't have to get into the nitty-gritty here. But what they're doing is they're not identifying organisms per se. They're identifying DNA that's associated with certain phyla, the large groups, and species and communities, but they're not actually identifying the organisms the way the culture technique did. So the good news is that they can do this very rapidly and they can identify large communities. But the bad news is it's not super accurate. And we have seen this in our own practice where we've had patients do testing the same day, and we've seen different results in terms of the percent diversity as well as the large families that I'm going to talk about in a moment. And lots of other people have reported that too, of a lot of sort of intra-individual variability and a lack of reproducibility of the results. So that's one problem. The other problem is that we don't know what it all means. And some things, so for example, let's go over the dominant phyla in humans. The four sort of commonest are Formicates, Bacteroidetes, Actinobacteria, and Proteobacteria. Generally in that order, there's been a lot said about the ratio. Formicates and Bacteroidetes typically make up 90%, and the Actino and Proteo less than 10%. So Formicates and Bacteroidetes are the two main, the sort of dominant families. And there's been a lot written and talked about the ratio, the Formicates to Bacteroidetes ratio. And this association that a high percent of Formicates, so sort of, let's say 76% Formicates and only 12% Bacteroidetes and the rest Actino, Proteo, maybe Verruca or some other sort of less common group, that a high Formicates to Bacteroidetes ratio is suggestive of obesity. And it is. But it's also suggestive of, 100 different conditions. So it's a general marker of dysbiosis. So I see that in my Crohn's patients, in my patients with colitis, in my patients with celiac disease, in my patients with dysbiosis, Sibo, all kinds of things. You see that ratio. I also see that ratio in very skinny people, high Formicates, low Bacteroidetes, and sometimes I see a normal ratio in very obese people. So there's no one-to-one correlation. And Formicates, that family is one that was common to people of Northern European descent who thousands of years ago had to weather a very cold winter without food. And so that sort of family was good at storing calories as fat to get these, our Northern European caveman and woman ancestors through a long, fallow winter where there was no food. Of course, there's plenty of food to be had now through the long winter. And so you don't know, if you take a very simplistic view and say, well, high Formicates is bad, then you are completely missing important points, like the fact that that is often an adaptation and not, the whole cause and effect, that high Formicates in people of Northern European origin is an adaptation for something and not a sign that they have a bad microbiome, if you will. And of course, that was thousands of years ago, so that's also changed. So the idea that you can do this profile and just say, oh yes, this equals that. It's the same. I have a slide that I use in talks where I talk about the Human Genome Project and the millions and millions and millions of dollars that were spent and the amount of physicians that worked on it and scientists. And, in the almost 3 decades, really 2 decades, since we've been able to sequence the entire human genome, how many genetic diseases have been cured? And of course, the answer is 0, right? Because the genes are just a suggestion. They're turned on and off, and some are expressed and some are not. And even as we're sitting here together on this webinar, we have genes that are being activated and deactivated. And the same is true of our microbiome. And so, for example, if you think of something, here's a great example. You think of something like syphilis, right? So syphilis is not a great thing to have from a disease point of view, and it's caused by a spirochete. But in parts of Africa, where in the Hadza tribe of hunter-gatherers, where they still are eating a lot of raw meat and raw blood, high levels of spirochetes are actually protective for them against getting certain forms of dysentery. So you see an example where in our super sanitized Western world, spirochetes are bad. You can end up with syphilis. And then across the big pond, spirochetes can have actual protective effect. So it's, we don't really understand this idea of adaptation and how we're adapted for our environment. And so labeling bacteria as good or bad, and even within big groups, like if we think of Clostridial species, we all know that C. difficile, Clostridium difficile is bad, right? So that's the kind of bacteria that can overgrow when you've been given antibiotics, especially if you've been exposed to someone in the hospital who has it, and can cause a severe infection, C. diff colitis. And we know that there are now 15,000 deaths a year in the US from C. diff colitis, and large numbers of people, increasing numbers of people being infected. But Clostridial species are also protective. Certain types of Clostridial species are protective in inflammatory bowel disease and other conditions. So to label Clostridial species as bad completely, again, sort of misses the complexity and nuances of how different families work. And again, we have to harken back to this concept of pathobionts, right? Of organisms that under normal circumstances are going about doing their business, being commensal, maybe even conferring a benefit to us as a host, but when overrepresented or in a geographic area where they really don't belong, now become a problem. So this makes all of this very difficult to interpret. One thing I can tell you, if you're probably used to the Ubiome report, you usually get a wellness match, and that's not helpful. There's a diversity score, which is a percentile, and kind of like SATs, the higher that number, the better. So if you have a diversity score of 4% or 6%, that's not good. But if you do the test the next day, the diversity score may go up dramatically, because a diversity score is graded on a curve relative to the other people being tested, to the other specimens. Because, of course, we don't have any sort of ideal, perfect microbiome to compare this to. So when they're giving you your diversity score, they're giving you a percentile based on the other specimens that are coming in. And so that's going to vary. And if you submit a sample today, your diversity score may be 46%, but that same sample in a different cohort could now be 80%. So it's relative, and it's very important for you to understand that the diversity they're giving you is relative, looking at other specimens they have. They're saying you are more diverse than 4% of people, or hopefully more diverse than 96% of people if you have a high percentile. In general, if you've taken a lot of antibiotics, you're going to have a lower diversity score. But of course, there are a lot of other things that contribute. Are you a heavy drinker, smoker, other things that can contribute, as well as the fact that it's a relative reporting out. So this issue of microbiome sequencing, and Leslie Ann will have a smile on her face as I talk about this. When this came out, we got very excited, and we gave this kit to everybody who came into our office, and we said, we're all part of this whole citizen scientist experiment, and we're contributing to the literature and the science, and we are in a way, but it was really not actionable for the individual patient. And the reason we stopped distributing them in the office is that, number one, the customer service for some of these companies is not great. And we got really tired of irate patients calling and saying, I sent my kit in 10 weeks ago and I haven't gotten results, and you said it'd be 4 to 6 weeks. So we said, get it from the company and you can complain to them. And we're happy to help you interpret your results when you get them, but we're not going to do customer service for this company. And then with the interpretation, that's another thing. People come in so excited, kind of like if you've ever done your 23andMe and you get your test results and then you realize, like, this doesn't really change anything, right? I still need to exercise, eat more vegetables, and, try to be less stressed. None of the stuff on the actual test makes a difference. And for me, when I did my 23andMe testing last year, I had some Alzheimer's in my family, and I came back positive for one of the genes. And it didn't really change anything. I knew I probably had an increased risk because lots of family members, but I also know that there are lots of environmental things. So the things I need to do of, eat a healthy diet, exercise, not drink too much, all of those things that we know are helpful, do lots of Sudoku, all the different things for Alzheimer's, it didn't change anything. And it's sort of the same thing here. If somebody comes in and they have classic dysbiosis, they've been on lots of antibiotics, they've had a terrible diet, all of those other things, and I get this testing, it doesn't change anything. Really what it does, it validates for people who have often been told everything's fine, you're stressed out, they've gone to the gastroenterologist, they've had an endoscopy and colonoscopy, it's normal. They've had a CAT scan, it's normal. They've had an ultrasound of the gallbladder, it's normal. They've had a HIDA scan for gallbladder function, it's normal. They've had all of this stuff and it's normal, and now finally a test comes back where, to be honest, there is no normal. We haven't really determined what normal looks like yet, but maybe there's some abnormal things on it, like low diversity or very high Formicates or a higher proteobacteria than we expect. So they're sort of excited, like, finally, right? Something is validating for me that all is not well. But I don't need microbiome sequencing to validate that. I know all is not well because they're telling me all is not well. They're telling me that they're having diarrhea and foul-smelling stool, and they're bloated all the time, and they're tired. And I know that that's not in their head, even though maybe their previous gastroenterologist told them that. So I find that this testing, it's a great idea to do if somebody has, $89 to spare, because it contributes to this larger database, and what they're really looking at is trying to figure out these microbial signatures of different diseases. So because of these large data banks of sort of biobanking, they've been able to find out lots of things. Like, for example, in Crohn's disease, we see an increase in invasive adherent E. coli. And we wouldn't have known that if we hadn't been studying patients with Crohn's and doing microbiome sequencing and so on. But the idea that you can do this test and it's now going to give you some sort of magic prescription for what probiotic to take or what to eat is unfortunately magical thinking. And I'll address this more in one of the questions. Somebody asked a good question about that. I will say that every now and again, I see one of these that really gives me pause. And I have a patient who was in a car accident and lost a lot of bowel. She had a perforated intestine that was unrecognized for a few days, and she actually ended up having cardiac arrest and being rushed to the operating room, and they discovered she had a perforated bowel and almost died. I mean, it's a miracle that this young woman is alive, wonderful young woman. And I have been working with her surgeon because she has a bag, an ostomy, and she's going to get reanastomosed this spring, which we're very excited about, and get rid of the bag and get the bowel put back together. And I had mentioned to him in an email exchange something about microbiome sequencing and her ubiome results, and he was unfamiliar with it. So he mentioned that he had another patient, a young woman who had lost a lot of her small intestine and had an ostomy, and they were having issues. And he said, "Do you think it would be helpful?" So I said, "Sure, this is how she can get it done." So he sent me the results recently, and I've never seen results like this. So typically, Formicates is somewhere between Formicates and Bacteroidetes, somewhere around 90%. And Formicates typically maybe like 55%, and Bacteroidetes maybe 45%, Actinol 4 or 5%, Protea 2 or 3%, somewhere like that. Her Bacteroidetes was 0.8%. Never seen that. I've never seen a Bacteroidetes under 10%. Her Proteobacteria was 66%. Over 5 or 6% we consider high. Over 10% we consider really high. The highest I had previously seen was 22% in a patient with Crohn's who had been on antibiotics literally for a decade, on and off, ciprofloxacin and metronidazole, Cipro and Flagyl. I'd never seen a Protea of 66%. I had no idea what it meant, and he called me. He's like, "You're the expert." And I said, "Well, this is really abnormal." That's what I can tell you. But again, we sort of know that. She's missing like 10 feet of small intestine. She's been on antibiotics for 9 months straight, and steroids and lots of other drugs. And, you know, everything is messed up in her small intestine. Everything is messed up, and it's not even together. So she had one sample from the ileostomy from the bag and another that was a rectal swab. So her gut is probably as disordered as it could be, because it's anatomically not even all together. It's separated. And then she's had every number of drug and really high dose broad spectrum antibiotics, because that's what's kept her alive, this other patient of his. So, you know, did I need microbiome sequencing to tell me that her gut was abnormal? Probably not. And I am quite sure that 10, 20, 30, 40, 60 years from now, they look at something like that, they'll be able to make more sense of it. But the truth is that in 2018, I don't have any more actionable advice to give him than I would to somebody else, which is make sure she's eating a lot of indigestible plant fiber, avoid antibiotics unless absolutely necessary, try and take off all these drugs that you have her on, except the ones that are essential. And she'd probably benefit from a high dose of a robust probiotic like the one we use in our practice. But there was no, oh, give her 500 billion colony-forming units of Bifido and 300 billion of this. I mean, that, again, that's total magical thinking, to think that we can, from any of these tests, create some kind of prescription. And if you've looked at some of these sites, and I won't mention any one in particular, but some of them advertise, you know, to what to me are fairly optimistic things and aspirational things that these tests can do. For example, one says, what if illness were optional? And that based on their testing, illness, you know, could be optional. Maybe one day, but not today. I'll say that. Okay. Question number 1. The Dysbiosis Checklist includes Blastocystis hominis, one of my favorite bugs. Does Dr. Chutkan treat this? If she treats it, does she recommend herbs or antibiotics? Is there any connection between B. hominis, Blastocystis hominis, and Sibo? I've heard various responses from functional doctors and others on this. For someone who has had Sibo, what would her general guidance be? I love this question because probably 10%, probably about maybe 5%, maybe 1 in 10 or 1 in 20 of the patients I see in my practice with dysbiosis and or Sibo have a positive test for blastocystis or for Entamoeba histolytica. So let's chat for a minute about blastocystis. It is a parasite. It is, we call Blastocystis hominis, hominis referring to humans, is a blastocystis that lives in humans. But blastocystis can live in tons of animals in the GI tract, in farm animals, in reptiles, in fish, in cockroaches, and amphibians, in many, many animals. And the kind that live in humans, we lump together as B. hominis, Blastocystis hominis. But within Blastocystis hominis, there are probably dozens of different species. So that's which we cannot or do not distinguish. Maybe a very good microbiologist could, but we don't distinguish between them. So again, we're lumping a lot of different species together. Blastocystis is the most common, and I'm going to put this in quotation marks, infection, parasitic infection in the US. And I say put it in quotation marks because it's not clear it's an infection at all. But it's somewhere around a quarter of the population in a study that was done in 2000, somewhere around 23% of the population. If we look at less developed areas, less developed parts of the world, or even rural parts of the US, where people live or work with animals, we see rates of almost 100%. So I feel like blastocystis is much like Helicobacter pylori. It's much maligned, and it has a bad rep that it doesn't deserve. Because, you know, when you see something, it's like, really, 100% of people are infected, and this is causing a problem? So if you look again at the symptoms that are attributed to blastocystis, it's virtually every GI symptom you could imagine. Diarrhea, constipation, nausea, vomiting, abdominal pain, bloating, gas, cramping, rectal itching. Any and all GI symptoms are attributed to blastocystis, which should be another red flag. And so people come in very excited. I've been feeling terrible. So a typical story will be somebody who, again, maybe not a great eater, lots of antibiotics. They go on safari in Kenya, and they get some sort of amoebic dysentery, and they're sick, and they have fever and bloody diarrhea and so on, and some erstwhile doctor puts them on an antibiotic, usually a bad idea because these are generally self-limited things, but you're out of the country and you're sick, so it's hard to fault people. They get an antibiotic and they come back and they're never the same. They sort of have now post-infectious irritable bowel syndrome, which is probably Sibo for most people, but they get a diagnosis of irritable bowel syndrome, and they just can't quite get back to how they were before they went on the safari to Kenya. And then they do some stool testing at the basic lab at Quest or LabCorp, and everything's negative because those labs tend to not be very sensitive, the assays and cultures they use. And then they do testing maybe with Genova or another lab, and they find out, wow, I'm positive for blastocystis, and now they're very excited. Eureka, I found it. This is what's causing my problems. I have blastocystis. So their primary care doctor is very excited. Yes, you have a parasite, and this is what's making you sick. And they put them on any one of a number of drugs we use for blastocystis. So probably the commonest is nitazoxanide. People use Flagyl too, metronidazole. They sort of use that for everything in the GI tract, which is a problem because it kills almost everything in the GI tract. But they get put on nitazoxanide for 3 days, which is a broad-spectrum antiparasitic, antiviral drug. We use it for crypto, giardia, etc. And they feel good for a week, kind of like the post-Xifaxan story, right? Because now the gut is a little bit sterilized. They feel good. But then 2-3 weeks later, they're right back to where they were. So then the doctor says, maybe you need another round. So they end up getting 3 or 4 rounds of treatment. They get nitazoxanide, they get Flagyl, they get all this stuff, and they're not better. And sometimes they're even worse if they get too many treatments. And that is because the blastocystis is not the culprit. The blastocystis is a terrain problem. The terrain has been messed up. They have gone on safari and they've gotten colonized with a lot of stuff, and they got sick, and maybe that dysentery, there was some kind of Shiga toxin or something that was produced that sort of decimated their gut, right? It killed a lot of their healthy bacteria, and maybe they had a secretory diarrhea where the colon was secreting all this stuff, and they got very sick. And then to add insult to injury, the doctor put them on Cipro and Flagyl, maybe not once, but 2 or 3 courses, thinking they must still have a parasite. So now they have really bad dysbiosis because not only has the infectious bug, whatever that was, let's say they had, I don't know, maybe they had cholera, but whatever that was, that has caused some decimation of the healthy bacteria, and then the antibiotics they get on top of that has worsened things. And so blastocystis, which could very likely have been in their gut all the time, but not in high enough levels to turn up on a stool test, kind of like C. diff. Many of us are colonized with it, but it's only when it starts to overgrow after a course of antibiotics, the way yeast overgrows vaginally after a course of antibiotics, and in the gut. So now it's showing up on the test, but it is true unrelated. It is a sign that the terrain is messed up. So when I see people coming with positive tests for blastocystis and Entamoeba histolytica, it's a terrain issue. And treating the blastocystis as the only thing you do almost never results in them getting better. And it often results in them getting worse if you're using something like flagyl or nitazoxanide. Sometimes people just sort of can't bear to think that they have this organism in them and they want to be treated. And so they do oil of oregano or wormwood tea or some garlic or something. I have less of a problem with that. The wormwood tea can be a little difficult and the oil of oregano you have to be careful with. Some people get a lot of nausea with it, but it's a less potent sort of bactericidal agent. But I try and reassure people that we're not going to worry about the blastocystis. We're going to crowd it out. We're going to cultivate some really healthy soil, and these sort of weeds that are overgrowing, like the blastocystis, are not going to be a problem. But I tell you, I see way more problems from people being treated overly aggressively for blastocystis and Entamoeba than I see problems from the organisms. Just like I see way more problems with our patients who are in DC, so we have a lot of international patients who work for the State Department or Peace Corps or various sort of international NGOs. I see way more people who are sick from the malaria prophylaxis, the Malarone and the Lariam and the Doxy that they're taking for months on end than are sick from malaria. So it's, I saw a patient in the office on Monday, and she's heading to Ethiopia in April for a month, and she already has really bad Sibo. And she said, well, they really want me to take Malarone. What should I do? I said, well, if it's a really high endemic area for malaria, I don't want you to get malaria and get sick, but at the same time, definitely don't take the Doxy because that's just going to ruin your gut. Maybe take the Malarone if you have to, but it's sort of a tough situation, right? And I said, if you decide not to take it, please don't get malaria and make me look bad. But again, sometimes the cure is worse than the disease, and this widespread prophylaxis that people are taking to prevent things that, don't get me wrong, malaria can be a serious illness, but often it's to prevent a little traveler's diarrhea that is not a big deal. You're going to have diarrhea for a few days and then you'll be okay. But if you end up taking 10 days of Cipro and flagyl, you might not be so okay. So you have to really think about that and not this knee-jerk instinct to just treat even if somebody has something. If you look at something, for example, like salmonella, we don't treat salmonella with antibiotics unless somebody has signs of severe systemic infection. So if somebody has salmonella and we're isolating it from the blood and they're septic and they're like in shock, they have a high fever and they're low blood pressure and they're in ICU, we treat salmonella in that situation. That's very rare. We get a positive test for salmonella from stool. We don't treat it. We specifically don't treat it. That is the actual official guideline. Why? Because when we treat it with antibiotics, it prolongs the carrier state. The salmonella goes into sort of a dormant phase, and now that person is a carrier, and they're at increased risk for infecting other people with salmonella. So you have to just sit and tell the person they're going to be okay, they have diarrhea, support them, lots of hydration and so on, and try not to use antidiarrheals because you don't want to block the salmonella and the toxins from getting out. You want them to eliminate and get rid of it, and just sort of watchful waiting and supportive care. And that's difficult to do because we live in an age where people do not want to be sick. They don't want to be inconvenienced with, having diarrhea for 4 or 5 days or even longer. But that's an example where an antibiotic can prolong the carrier state and is a bad idea. So if the last part of this question, it was such a great question, for somebody who has had Sibo and has blastocystis, I would not treat it. And again, if you have Sibo, chances are you have diarrhea, constipation, nausea, vomiting, abdominal pain, bloating, gastrorectal itching, at least one of those symptoms that's also being attributed to the blastocystis. I would sit tight and I would really work on my terrain. I would drink, 2 big green smoothies every day, tons of plant fiber, good probiotic, get rid of everything in the medicine cabinet that I can get rid of, and I would really work on that. and I would see how I feel. And, maybe retest down the road, but at the end of the day, it's really about how you feel, not what the test shows. Okay, let's go to the second question. The connection between Sibo and type 2 diabetes and hyperglycemia. So if I could draw you a graph where I could show in the last century, a decrease in communicable diseases like tuberculosis and cholera and so on, and an increase in non-communicable diseases like diabetes, asthma, heart disease, autoimmune diseases. So as we sort of super sanitize not just our country, but more and more the world, right, the developing world too, we see fewer people dying from tuberculosis, cholera, et cetera, hepatitis, but more people developing these modern plagues, as they've been called, of autoimmune diseases and diabetes and so on, non-alcoholic steatohepatitis, fatty liver disease. And so this is both cause and effect. Sibo can lead to a decrease in short-chain fatty acids. And short-chain fatty acids are very important for not just breakdown of fat, but glucose metabolism. They affect glucose metabolism. So the decrease in short-chain fatty acids, if you remember from the first webinar, and I remember I provided for your reference that lipid article that's like everything you ever wanted to know about short-chain fatty acids. So Sibo can cause decreased short-chain fatty acids, can affect glucose metabolism. So that's one way that Sibo can cause diabetes. But diabetes, of course, can cause Sibo, because one of the commonest things that diabetes does is it leads to alterations in gut motility. It can cause it to be too fast or too slow, but more commonly too slow. It causes gastroparesis. It affects the nerves that control the emptying of the gut, and that leads to stasis of the gut contents and Sibo. And there was a study done that showed that, I didn't include it in my prevalence, but one study showed that 43% of patients with diabetes, of type 2 diabetes, not type 1, type 2 diabetes, had Sibo. So it can be both cause and effect, and it's important to think of this communicable versus non-communicable. Think of communicable diseases as more classic infectious diseases, real infection, not pathobionts, not sort of could be, but really like Ebola and TB and things that are clearly not a great idea to have. And then non-communicable diseases, think of those as a modern plague, sort of, MS, lupus, heart disease, asthma, that kind of thing. So you see one going up and one going down, and the shared factor in all of this is really supersanitization in a more generic sense and changes to the microbiome. The next question, do you recommend a 2 or 3 hour lactulose breath test? I generally do the 3-hour test if the patient has delayed transit. So I tend to do the 3-hour test now that it's readily available in almost everyone, because if somebody's delayed transit, the 2-hour test might not show that spike. So that's the answer to that one. The fourth question, Dr. Alison C. Becker talks about differences in treatment depending on whether hydrogen or methane are elevated. Do you agree? And if so, what would be the different treatments? Again, I wish it were a simple thing like, oh, you have methane predominant Sibo, so therefore we do this, and you have hydrogen predominant, we do that. The general sort of remove, replace, restore of remove the offending agents, drugs, et cetera, and the other factors, replace as much of the gut bacteria as you can, and restore the health of the gut through food, something we're going to spend a lot of time talking about next week. That still applies, but I will support them differently based on whether they are having constipation or diarrhea, not based on the hydrogen or methane level. So if somebody's very constipated, even if they have a methane of 4, it's not over 10, or it's not greater than or higher than 10. So it's not elevated, but if they're really constipated, I'm going to treat their constipation. So I may give them a combination of a fiber supplement, some psyllium husk if they can tolerate it, some acacia fiber if they're not as good with psyllium, and maybe a little bit of magnesium or various things. So that's not going to be based on the breath test result. That's going to be based on the clinical symptoms. Okay, I'm going to go to the next question. Number 5. Where can patients get the glucose lactulose breath test for Sibo? I'm an RD, a registered dietitian. I'm not sure if I need to send them to their PCP or GI doc, PCP, primary care practitioner, or GI doc, or if this is something I can order and how they do on their own, and have them do it on their own. So any licensed healthcare professional, if you're licensed in your state, can do it. MDs and DOs, I think, are automatically licensing in the 50 states in the sense that if I'm a gastroenterologist in good standing with an active license in DC, I can order this test for somebody in New York, for example. But it varies state by state. So if you are a registered dietitian, so you're a licensed healthcare practitioner, you should be able to order the test. And there's a way you get, for example, the breath test. We usually order the breath test through Genova because it's the same test they use at the hospital. And we just find most people prefer to do it in the comfort of their home. Some patients who it seems a little much with the mixing up and drinking and breathing is different things. Sometimes some of our patients who are older or just not as facile with testing want to go and do it at the hospital, but we usually give them the kits to take home. And I think you can contact them, or anyway, we're not suggesting that Genova is who you should do it with. That's just the one we do. I don't have a preference. But again, I would look at the reagent and the amount and so on and make sure that, you know, they're sort of adhering to the consensus guidelines such as they are. And I think with your license as a registered dietitian, you should be able to order it, but I don't have a 100% answer for you on that one. Number 6, are there any particular issues? And I apologize, we're right at about 10 o'clock here. I'm going to take about an extra 15 minutes for anybody who has to sign off. This is going to be uploaded. I don't think we have to re-record, so it should be uploaded. It should be available in a day or two if you have to sign off. Thank you for joining us. I'm going to keep going. Are there any particular issues associated with a stool that forms a visible film over the entire surface of the water in the toilet bowl? Now, I'm a huge advocate of what I call turning around and taking a look. You must look at your stool, and you must tell your patients to look at their stool, because stool can tell you a lot, right? It's like reading tea leaves. You want to look for blood. You want to see if it's falling apart. Is it loose? Is it super hard? Is it little pebbles? Is it shredded? And does it look oily? Is it fatty and floating? So it's very important to look at your stool. The visible film, though, can be lots of things. So if you are ingesting a lot of oil, and people these days are using a lot of essential oils, not just topically on their skin, but ingesting them, that can leave an oily residue. People who are taking cod liver oil supplements can sometimes do it, or even some fish oil supplements. But a visible film over the entire surface of the water, you might think about fat malabsorption, especially if the stool is floating, and it tends to be sort of more foul-smelling than one might expect. Of course, it's relative. And if you suspect that, there are a couple things that you can do. You can do just a quick qualitative fat analysis where they look at the amount of fat droplets in the stool, and more than a certain amount of fat droplets per high power field is considered abnormal. And I like to do that first before the quantitative, because the quantitative tests of fat malabsorption, I'll say that the vast majority of people who think they're malabsorbing fat are not. It's mostly people who have, you know, things like tropical sprue, or people who are immunocompromised, some AIDS patients who have CMV and things like that, or people with pancreatic disease. So the average person with Sibo is not having the degree of fat malabsorption where it's going to show up on a quantitative fecal fat analysis. And for that test, one of the most important things is to make sure that the person is actually eating enough fat. When we do the 72-hour quantitative fecal fat, stool fat study, you have to be eating 100 grams of fat a day for the 3 days, and you have to collect it in a special container. So if you're eating a low-fat diet, you're going to have a low amount of fat in the stool, and that could be a false negative test. So the first thing you have to do is make sure the person is on a high-fat diet, on eating sufficient amounts of fat in the diet for the 3 days of the test for that fat to be malabsorbed and show up in the stool. Okay? Because if they're on a low-fat diet, they're not going to have enough fat in the stool, even if they are malabsorbing it. So I start with the qualitative. Just send it off for a spot fecal fat, and they do the stain. Yes, there are more than 5 droplets per high power field, whatever the cutoff is. And then I will call the patient and say, okay, now you have to do the 72-hour quantitative that's going to quantify and tell us exactly how much fat you're malabsorbing, and you have to have a special diet, and here's a special container, etc. But all of this is to say, I don't think a stool that forms a visible film over the entire surface of the water in the toilet bowl is enough on its own to warrant an evaluation for fat malabsorption, unless the person is also, they're having difficulty losing weight, and they're losing weight, having difficulty maintaining their weight, and they have other evidence of fat malabsorption. It might be a supplement. The commonest reason is probably a supplement they're taking. So I'm going to move on. Number 7, please explain how the graphic on page 35 relates to the text on that page. I think that was a very confusing inflammatory bowel disease picture we gave of NOD2 gene, etc., which I would ignore. And I think based on the feedback we've had, I probably should have left out that inflammatory bowel disease stuff. So please ignore. Number 8, the last sentence on page 32 refers to effective donors. Please explain. I believe that's a study where they talk about a bifido-rich donor in irritable bowel syndrome resulting in alleviation of IBS symptoms with an effective donor. And by effective donor, they meant in the donor that was rich in bifidobacterium. So for these patients who had irritable bowel syndrome, where the presumed etiology was Sibo, when they did fecal transplant with donors that had high levels of bifido, and again, hard to create this hierarchy, but let's just call it a good bacteria for the purpose of the discussion. When they got a stool transplant from donors that had high bifido, they had better relief of their symptoms. So effective donors refers to donors that were higher in bifido in that experiment. And I hope that explains it. If that does not explain it, just send us an email and I'll try and do better. Number 9, I like this one, how to test and improve the ileocecal valve, if only. So the ileocecal valve is a sphincter that connects the end of the small intestine, the ileum, with the beginning of the colon, the cecum. And unfortunately, it's not under voluntary control. And like most things, as we age, it tends to get loose, which is probably part of the reason why we see higher rates of Sibo in older people, because we have more, instead of, normally the intestinal contents are quite liquid. So when the stool hits the colon, the top of the colon, the cecum, it's quite attractive. It's sort of green bilious stuff. It's like a greeny sludge. It's not what most people think of as stool per se. And it doesn't have a strong odor to it, like when it comes out all the way out at the end. So it's a sort of greeny bilious sludge, bilious meaning lots of bile in it. And it can be very liquid. And it comes through the ileocecal valve, and the ileocecal valve opens up and lets it into the colon. There are peristaltic waves in the small intestine, and it lets it in a bit at a time. It doesn't dump it all into the colon all at one time, because as you can imagine, that could overwhelm the colon, and your colon could end up full of stool, and that wouldn't be good because you might have less control. So it releases it in a timely fashion. And when you don't have an ileocecal valve, either because you've had a resection of that area, most commonly if you have Crohn's disease, that's the area that's commonly affected, or let's say you're in a car accident and that part of the bowel is damaged and they have to remove it, or as you get older, the sphincter becomes less competent. It's not as tight. It's like the rest of the body, right? Things are just not as tight, like wrinkles on the face or anything else. Valves don't work as well as we get older because they're muscular structures and the muscles stretch out. So unfortunately, there is not a way to improve that ileocecal valve, but it's not a super relevant thing. It's not like, gosh, if you have a stretched out ileocecal valve and it's not as competent and now contents from the colon are refluxing up into the small intestine, that's generally not the sole factor that would contribute to Sibo. It's just one of the mechanical sort of motility things that would. So unfortunately, we can't sort of tighten our ileocecal valve doing exercises. And the only way to really test for it is during colonoscopy. And we're not even really testing valve function. We're just looking at it anatomically. So we can do motility testing in the GI tract, but not the ileocecal valve, to my knowledge. But I wouldn't spend a lot of time worrying about how to improve it. Number 10, do you think stool tests help with determining type of probiotic treatment? Example, my gut Zoomer test indicated I need more lactobacillus versus bifido. Absolutely not. I think I touched on that earlier, or maybe did more than touch on it. It would be great if it were some sort of great analysis and you need some of this and some of that, etc. Doesn't work that way. We all need more plant fiber. Number 11, do you use comprehensive stool analysis like the stuff Genova has to assist in diagnosing dysbiosis or Sibo? I do it. I mean, this is a question this is a point I was making earlier when I talked about the Ubiome stuff or the Genova stuff. It doesn't change anything. I do it, honestly, if I think it's helpful to the patient, where they are struggling and they've been told everything is fine and they sort of need something tangible that they can wrap their mind around with this diagnosis, or if I think it's going to be really interesting and sort of unusual because of their interesting or unusual circumstances, like the young woman I mentioned, the other patient of my surgical colleague down in Florida, where she had this crazy high proteal level. But so it's a difficult question for me to answer because I often do get it, because I also do believe that if the patient's curious and can afford $80 and is willing to do it, you know, it's just always sort of interesting to see, and even just for my own sake to see, gosh, in my Crohn's patients, I'm really seeing this versus, you know, in these patients, I'm seeing that. So really, because it helps us potentially advance the science as a community, but it's generally not really actionable to them per se. If somebody comes in with a classic history, signs and symptoms of Sibo, regardless of the breath test or the stool test, I'm going to treat them. And if somebody comes in, and that happens quite frequently, the breath test is negative, but they have classic signs and symptoms, and I treat them. And then people often want to know, well, should I repeat the breath test? And I say no, because if the breath test now comes back negative, but you're still symptomatic, obviously our work isn't done, right? And if you're feeling great and the breath test comes back positive, we don't care. We're not going to, you know, we're done. So I hope I at least answered a little bit of that question for you. Number 12, this is a terrific question. This sort of sums up where we are in integrative gastroenterology. How do you distinguish between clinical entities like leaky gut, dysbiosis, Sibo, yeast overgrowth, food sensitivities like gluten intolerance and lactose intolerance? How do you distinguish between all of this clinically and with diagnostic testing? Do you have an algorithm for working through this myriad of integrative GI problems? Again, I thought this was such a great question because it really kind of sums up where we are. And what I'd like to use some more conventional diagnoses as a paradigm for this. So I want you to think about diabetes, coronary artery disease, so heart disease essentially, stroke, and obesity. Okay, I want you to think about those four things: diabetes, heart disease, stroke, and obesity. And two of them, diabetes and obesity, type 2 diabetes and obesity, are so commonly correlated that we even have a term for it, diabesity. It's so common. Those four things are all fellow travelers, and we have different tests for them. So the test for heart disease might be coronary artery imaging or an EKG. The test for diabetes might be a fasting glucose or hemoglobin A1C. The test for a stroke might be angiogram of the carotids, or more commonly, it's some testing after the stroke has happened, like a CAT scan of the brain. And the test for obesity is a BMI, or eyeballing the patient. And these are all four different diseases, but they all have common etiologies, multifactorial but common: diet and lifestyle, plus minus a genetic predisposition, right? So we think that there's a genetic predisposition for heart disease, diabetes, etc. But the bulk of it, a huge percentage of patients who have these things, is diet and lifestyle. And the same is true for the things we're talking about here, like leaky gut, dysbiosis, Sibo, yeast overgrowth, etc. They're all connected. I would put a lot of these things under dysbiosis. So again, when you have yeast overgrowth, you don't have an infection. It's a terrain problem. So the microbiome is sort of, the ecosystem is imbalanced, and now some species are growing where yeast, they shouldn't be. They're sort of behaving like pathobionts. There is, when the ecosystem of the microbiome is disrupted, there's often an increase in permeability of the gut lining, because if somebody's been doing something like taking nonsteroidal anti-inflammatory drugs, all the more, because that's really increasing the permeability. But just a disruption in the microbiome can lead to an increase in permeability. And so now you have an increase in intestinal permeability, which is essentially what we call leaky gut. And now you have food sensitivities, because now partially digested rather than completely digested particles of food are traveling through the gut lining and triggering an immune response. And you also have Sibo. So they're all connected. So I think rather than thinking of them as separate things, it's helpful to think of them as a disordered ecosystem. And it's not just microbes, right? Microbes are what we're talking about tonight, and the microbiome is what we're learning a lot about and so on. But 50 years from now, there might be something called the etherome, I just made that up, or the platysmome, or something else. And it will be, they're not bacteria, but maybe it's a change in gases. It's the ether. It's something that we didn't know about, or something to do with hormone levels, digestive hormones, serotonin levels that we couldn't measure, we didn't know. We sort of knew serotonin was important. We knew that 90% of it was in the gut, but we didn't really understand changes in serotonin. Some other thing that will prove to be important. So this is one area where we should be lumping instead of splitting. Rather than trying to say, well, you have leaky gut and you need to do this, and you have Sibo and you need to do that, and you have yeast overgrowth and you need to do that. We should think of these things all together, the way we think of this sort of metabolic syndrome, right, where people have hyperlipidemia and hypoglycemia and so on. And so it's when somebody has Sibo and they clearly have dysbiosis, I don't necessarily do an intestinal permeability test, because it doesn't make a difference. It's not going to change. It's not like, oh, your intestinal permeability test is positive, so you are going to get a completely different algorithm for treatment than somebody whose breath test is positive. We'll talk about, this is a great segue into next week, where we talk about treatment, and we do support people based on symptoms. So somebody who's having a lot of gas and bloating and constipation, I'm going to approach differently from somebody who's having a lot of diarrhea, for example. But it's not like these are completely separate things. And again, a disordered microbiome is one of the major things that contributes to these things. But when you get to something like food sensitivities, it's complicated, and it's not always just the gut that is really playing a major role here. Okay, we have 2 more questions. And gosh, we're at 10:18, so I'm going to finish up in a few minutes. Is microbiome testing an important tool in diagnosing Sibo? If so, can you give us some pros on interpretation? I think we covered that. We spent some time talking about that. But again, if you feel like you need more information, let us know. Number 14, this is a great one to end on. Is testing essential if there is a known exposure to a foodborne pathogen resulting in diarrhea and IBS? I think it's a good idea if somebody is actively ill. So if somebody, whether they're here local or they're coming back from Burkina Faso and they have had a diarrheal illness and they're quite sick, I will send their stool to a good lab. I tend not to use the large commercial labs here in town like Quest and LabCorp, because I just find that they have very low rates of detection. And I tend not to use labs like DSL, Diagnostic Solution Laboratory, because I find everybody has 6 things. I saw somebody yesterday in the office who had a positive test for Giardia, Crypto, Blastocystis, and a 4th thing. And I think she has none of those things. So some of the tests are, I think, just a portal of entry to sell you supplements. And lots of these companies that do the testing also happen to own the supplement companies that they're then trying to sell you on. So I use, for example, if I think that somebody has something infectious, I use a lab in Arizona called PCI, Parasitology Center Incorporated, and I think they do a good job. And I like to know what it is, because if it is something like Giardia and they're very symptomatic over a long period of time, I'll treat it. On the other hand, if it's Salmonella or something like that, I won't. And because there's so much C. diff, I send C. diff in anybody who's having an acute diarrheal illness I'm going to send a C. diff on in addition to, so I send for 3 things for culture, which is looking for things like Salmonella, Shigella, E. coli, for ovum parasites, and then for C. diff. Typically, those are the 3 basics, the minimum that I would send. I think it's helpful to know what it is. And also some of the things are reportable. So for example, if there's Salmonella, you need to report it to the public health department. So that can be helpful. But most people who have exposure to foodborne pathogen and then get a sort of post-infectious IBS, you don't isolate anything in most cases, but it's still not a bad idea to look. So I think we're going to end there. It's been a pleasure joining you. I only wish that I could be speaking to all of you in some way, either virtually or in person, because I know you all have so much to contribute and probably lots of questions that we could talk about all night. So I'm only sorry that I'm sitting here on my computer with my headphones on and not with you in a room, but maybe in the future. And again, I want to thank all of you. I hope I've answered your questions. Again, it's a little bit tricky when we have both patients and practitioners, but I feel like we're all in this together looking for answers. Please give us feedback, good, bad, or indifferent. If this wasn't scientific enough, we want to know. If it was too scientific, we want to know. If there's a different format that you think would work better in terms of getting questions answered, please let us know. And we look forward to webinar number 3 with you next week. Have a wonderful night, everyone.